So the purpose of coming to chat with you guys today was sort of let you know that I'm in the area and also just let you know what I do. Plastic surgery is sort of one of those specialties that's consumed by a lot of other specialties as well. We offer a lot of other stuff that you may not be aware of, and any of the things you see me present on today, I'm happy to see patients in regards to that. So please feel free to call me if you want to ask whether I'd be interested in seeing it, or if you think it's along the lines of what you've seen today, just send them along. So I'm in the Central Coast every Thursday, mainly down at West Gosford in rooms down there, or operating out of Gosford Public or North Gosford Private. Otherwise, I'm in Sydney. My public hospital there is St Vincent's, which is mainly head and neck sort of reconstructive service there. But we also do with all the facial traumas, we get all the king patients there and do a lot of skin cancer work. Otherwise, I do a lot of breast reconstruction, and that tends to be more on the North Shore and Marta. Breast reconstruction across Australia is about 10% of reconstruction after breast cancer. But at the Marta reconstruction rate's about 45%. So it's a lot higher. We have a close working relationship with the breast surgeons there. And I've got the same relationship up here with Sharon Lara and Fred Clarke, the main guys doing breast cancer surgery. And we've already done our first free flap up here last month. So bilateral breast reconstruction, immediate breast reconstruction. So rooms in West Gosford, rooms in Mossman, and also Macquarie University Hospital. So I'm sort of spread out. I do the full range of plastic surgery, but the main things you guys would use plastic surgery for in the past would be difficult skin cancer work, so full range of local flaps, or getting into head and neck territory, so recurrent SCCs involving ears, another SCC, using temporary cryo flap to cover exposed bone and grafting that. All cases I've done. A guy with a microadnexal tumour involving his just lateral to his commissure, wide excision and a local flap using a submental artery to tunnel up to reconstruct that area rather than put a graft on there. It's a much nicer result. This is a guy I did last week, so SCC going through the back of his head, through the bone, into dura, right over his transverse sinus. So, nose and throat surgeon did the skin resection, neurosurgeon took out the cranium, took out the dura, did a dural repair, then put titanium mesh over, and I've come along and done a trapezius flap, so raising the skin panel from down here on the vessels and tunneling it up to cover the defect at the back. And free flaps, which we'll cover later on. In terms of special areas of the face where plastic surgeons are sort of often involved, and is around the eyelid. I'm interested in ocular plastics. I'm on a master's in ocular plastics and work with an ocular plastic surgeon each month. Also a lot of skin cancers, so of the lip, so truck driver with SCC of his lip, involving from here to here, so 2/3 of his lip, so we've done a lip switch reconstruction for him. Left him with a slightly smaller lip, but all can be done. A vermilionectomy with resurfacing using a tongue flap, straight wedges, just a chat from last week, so a wedge. It was initially tight, as you can see now, there's no tension across that lower lip. Back, ears, so there's local flaps, all these cases, skin cancer cases. Lady had Mohs surgery and had a skin graft, and she wasn't eligible for Medicare because she was from overseas. So she had to sit out as a teacher with a skin graft on her nose and this exposed septum and alar cartilage. We came along when she was Medicare eligible, which is a 3-stage reconstruction from the nose using a forehead flap. Another nose from last week, so just options that are available to patients where you don't have to do grafts. And with grafts, it heals the area, but it always brings in a patch to the area. It will always look like a patch. Whereas if you can use skin in the area, if you follow Harold Gillies' principles of comparing like with like, you're able to get a much nicer long-term cosmetic result. So this scar went up in his nasolabial fold. Scars up here on the nose don't tend to be so apparent over time, and then he's left with this skin to repair that malar defect. So also a lot of trauma, broken jaws, get those every week, and I'm happy to treat broken jaws if you get them. A lot of these can be treated as a sort of a semi-urgent type case, so giving the mouthwashes, pain relief, sending them along to me with a CAT scan and an OPG, and then we can stage their repair. So, arch bars here, plates, condylar fracture, all manner of things, frontal sinus fractures. Orbital floor fractures, all commonly done nasal trauma. I'm happy to deal with broken noses immediately or delayed. With the fractured nose, my approach is try and do a closure reduction straight up. 75% of them will get a result they're happy with. 25% you then have to go back and do a formal open rhinoplasty, which you would do probably about 6 months after the closed reduction.
Immediately, is it 1 day, 2 days?
2 weeks.
Within
2 weeks, yeah. Any of the facial trauma, if you rule out a problem with their eye, then essentially, and that's clear, then you can sit tight and refer them to rooms if they're comfortable. If they're uncomfortable, or if they've got an open wound or eye entrapment, then they need to go to the emergency department. But if there's none of those things, the rest can be done through rooms. Reconstruction options that things I deal with and happy to do, and my fellowship last year was in reconstructive microsurgery. Most of it was breast reconstruction, so may or may not be aware, breast reconstruction, you have implant reconstruction of your own tissue. The most common site for own tissue is using the tummy tuck tissue. In the past, we took the tummy with the rectus abdominis muscle. We don't need to do that now, so you can leave the rectus abdominis behind. We have to do a CAT scan first, a CT angiogram, to identify the vessels, perforators coming off their deep inferior epigastric vessels. If they've got a good perforator, then we can split the muscle, release the vessel, take the skin and the fat, leave their rectus behind, so don't destabilise their core. Just showing the vessels coming up from the femoral and then providing a perforator. So immediate reconstruction, so day before surgery, 2 weeks after her immediate reconstruction. So all she's lost is the nipple areola complex. The breast tissue's all been taken out through this periareolar incision. Scooped out all the breast parenchyma and replaced it with her tummy. And the only defect apparent will be this skin panel, which we will go back later on and make a nipple from. And so when she's healed and tattooed, we'll be hard pressed to see a scar on those breasts. That leaves a bit of a long scar down low, which we've deliberately sort of put in the knicker line. It's about the level of the caesarean section, but just goes wider. Another immediate reconstruction. If they don't have a good tummy, the other spot we can use for reconstruction is the medial thighs. So if they've got a sort of a fattier leg than tummy, then you can do a flap using the inner thighs. To reconstruct a breast with a sensitive breast is a little bit smaller in size, so maybe up to about 300 cc you can do in that way. Head and neck reconstruction, so the full gamut from the skin defects you saw before to oropharyngeal defects. This one's a laryngopharyngectomy, reconstructing the esophagus with a piece of jejunum. Sometimes use the thigh or the forearm to make a tube, replace the esophagus. They end up with a laryngectomy, so they have an artificial voice. The big workhorses for free flap reconstruction is the radial forearm flap. The skin's harvested from here, which has the vessels up to the cubital fossa, and then do a plumbing job to recreate the blood flow in those flaps. So for this guy, is hemicholecectomy. For this guy, big defect, big SEC over the longest parotid, so superficial parotidectomy, preserved his facial nerve, and then a big skin paddle to replace the defect. And you can see already with this patient that is a colour mismatch to the rest of him. Because when we did that submental flap, the colour match is much better. So if you knew skin in the same area, it's preferable. In this chap, he couldn't because he had all the nerves dissected with his SEC, and so the vessels that could have supplied that submental flap divided, so you have to bring in a free flap. Lower limb reconstructions, work with the orthopedic guys when they put in plates or someone has a big compound fracture that needs soft tissue coverage, where the guys come along and fix those. So gastroc here being raised, laid over that exposed hardware, and the skin graft. Guy's foot went under a bus. You know, at first it all looks pretty dramatic, but once you clean it up, vacuum for a long time, the skin graft and get away quite a lot. Sort of newer developments is the management of lymphedema. So in the past, 40% of ladies have axillary clearance with their breast cancer end up with lymphedema. In the past, the treatment's been non-surgical, so a lot of massage and garments. But now there's a new wave of enthusiasm for surgery to reconstruct the lymphatic channels. And one is either by bypassing the obstructed lymphatic channels and diverting the obstructed lymph into veins, called an LVA, and showing some promise. And the other is patients where it's probably a little bit more advanced, the lymphedema, and you bring in a free flap of vascularised lymph nodes from the groin and reconstruct their axillary lymph nodes. And that's early days, but there's now clinics being set up in Sydney, and this surgery's on the scheme of things is not difficult to do. It just promise for repairing or correcting lymphedema. Also do a lot of electric hands, so carpal tunnels, tubular tunnels, Dupuytren's disease, dealing with all of those. And then the full range of cosmetic patients, blepharoplasties, the body lift after massive weight loss, the deflated ptotic breast after babies. And we've got gynecomastia and paediatric cosmetics, patties, circumcisions, no trouble. So I've got cards. You're welcome to have my mobile number. You can ring me directly if there's any questions. If you've got any patients you're concerned about, want to run it by me, call me. Happy to take calls any time. My phone's always on. I'm on the coast every Thursday. Otherwise I'm in Sydney. If I can't deal with it there and then, I can bring patients to Sydney if need be. I have a once a month list in the public hospital. I don't have, I don't have any patients on that waiting list. So if you've got patients that need to get done, send them to me, don't send them to the other guys because I wait. But obviously that'll fill up.
Is that a Gosford or a Gosford Methods?
That's a Gosford.
Gosford, okay.
And St. Vincent's. Yeah. And Gosford Private are there every 4. So you're welcome to send anything like that along to me.